All right, we've got a 4-year-old with a large right hemispheric mass, and the patient has had a partial resection. So I'll show the MR first, and then the CT. Got all three projections. It's an ominous-looking lesion. It's so big that you might wonder for a moment whether it's intra or extraaxial, but only for a moment. You can see brain tissue around it. It's obviously bulging underneath the fulcs. It's twisting the brain stem. There's obstructive hydrocephalus. Look at the compression of the brainstem, rather dramatic, even after decompressive craniotomy. And there is displacement of the uncus inward, so there's uncal herniation evolving. See, is there intraventricular invasion? There's certainly ventricular compression. I think there is. And it looks like there is involvement of the dura as well. Are there any distant areas of disease? You know, there are certain tumors that like to seed the brain, and you should have that in your list. So what are the seeding tumors? Well, medulloblastoma would be a classic one. Ependymoma, very aggressive astrocytic tumors can seed. Oligos can seed. Neuroblastoma, primary neuroblastoma of the brain will seed. Aggressive choroid plexus tumors may seed. All right, let's take a look at the CT now. It's a non-contrast CT. So a little bit of calcium present, but not a lot. Actually, I'll have to take that back. A lot. A lot. And typically the calcification, it wouldn't apply here, but for you adult radiologists, typically the calcification of an oligo is very branching. This has some branching characteristics to it, but the rest of it is more or less random. But this is what oligo calcification would look like. All right, we have a follow-up MR, and I'm not sure that really adds a heck of a lot. It doesn't. All right. So how would you narrow the differential diagnosis? Pretty difficult, really, for the patient, but as far as the differential, it's very limited. So what things would you consider? Dr. Schupek, what things would you consider? Huge lesion, 4-year-old, intraaxial, calcified, aggressive looking.
Yeah, some sort of embryonal cell thing, or, you know, I was wondering when I first saw it about atypical teratoid rhabdoid, although the patient's a little old for that.
Arc tumor, yeah.
Fine. Usually that's kind of 2-year-old and below. So, you know, some sort of medullo or PNET or something like that, something, you know, very undifferentiated and aggressive. Now, I gave some thought as to choroid plexus origin, but I don't really think it's diverting the ventricle, but probably doesn't have its origin in the ventricle. I mean, that, you know, this thing is so big, but, and also I think the enhancement pattern for like a choroid plexus carcinoma or something like that, I think we put that in, but I think that's very unlikely.
Yeah, choroid plexus malignancies do have this sort of very gyriform, kind of frondiform look to them, which this has a little bit of that, but I agree with you that it's it's epicentered in the parenchyma going into the ventricle rather than in the ventricle going out. And, choroid plexus tumors are one of the few tumors in children with a predilection for the supratentorial space. And for whatever reason, it likes the left lateral ventricular trigone more than the right. Maybe we just have more choroid plexus tissue there. I don't know the reason for that, nor does anyone else, but it is a fact, a weird fact. Maybe another consideration might be primary neuroblastoma of the brain. I've only seen 2 of those in my entire career. They are aggressive. One thing I'll say about them is they are the tumor that bleeds more frequently than any other tumor. Oligo is a big bleeder. Neuroblastoma, as I've already said, is a big bleeder. Very large glioblastomas are bleeders over 90% of the time. So that would be one that I might have considered. PNET would have been one of my top choices. This was your case. PNET kind of in the family of medulloblastoma type lesions. There's quite a bit of overlap between those 2 now, and we'll discuss the genetics of those a little bit later on.
Right. But I mean, the other issue is, you got this giant mass, but so remember we were talking about the basilar cisterns, smashed, okay? Midline shift, okay, diversion of the temporal, this ventricle, but probable trapping of that one. Okay, so these are all things they need to know about, and herniation, probably, right? Uncle herniation.
Yeah, there's uncle herniation.
And then subfalcine herniation.
Subfalcine herniation.
So you need to describe all these things so that, because there's going to be a long-term treatment, but there also may need to be a short-term treatment to divert some disaster here. So the presence of basilar cisternal effacement and various types of herniation are going to be very important as to what they decide to do and when, meaning they may put an external ventricular drain in before they definitively, to deal with at least the obstruction before they deal with the definitive tumor. Now, they did a biopsy here, and actually it looks like it was an open biopsy, not a needle biopsy, which I think is kind of strange in the sense that, like with this mass effect, you're going to have to decompress. So it seems to me if you're going to go to the trouble of doing a craniotomy, you should try to take some tumor out, So I probably, and I mean, the diagnosis is interesting, but really what's on the verge of killing this patient is the mass effect. So, you might just do a surgery and figure out what it is at that time, but decompression is going to be pretty extreme need here.
And I agree with you that, the patient's old for an ART tumor. I mean, most of the time, ART tumors, atypical rhabdoid lesions occur before age 2. Average age, I think, is 1.2 years of age. So even though a patient's very young, too old, and they don't have this sort of really crazy gyriform pattern of enhancement. So, I do like, primitive neuroectodermal tumor or the family of embryonal cell tumors which kind of fall into that spectrum for this lesion, and I believe that's what it turned out to be.
Right, I think that's right.
Yeah.
And also, the PNET category has been sort of removed. It's now called, ETMR, I think, which is with embryonal cell tumor with multiple rosettes.
And we will show you some slides related to that shortly.
Now, does this diffusion restrict? I guess we don't have a diffusion.
We do not have a diffusion.
But this is one of those small cell tumors with not much cytoplasm, and so these very well may diffusion restrict.
And anything that's in the family of medulloblastomas is going to diffusion restrict, because when you think about what medulloblastoma looks under the microscope, there's no cytoplasm. So very tight. Remember our diffusion restriction criteria, sodium, potassium, ATPase, pump destruction, infarction, hypoglycemia, transient global amnesia, etc. Then you've got cell packing. We said lymphoma was the prototype. Well, medulloblastoma in the brain is a prototype for cell packing. Really, really tight nuclei. And then we said squamous cell and a few others that have very little cytoplasm. We said high viscosity, like an abscess or blood. or necrosis, and then tissue vacuolization, which can occur with CJD and with heroin abuse and a few other unfortunate disorders.
Now, one other thing about diffusion restriction, one other thing that diffusion restricts for the same reason, that is tightly packed cells, is lymphoma. And lymphoma, we're going to see in some of these other tumors, very important distinction, glioma, lymphoma, okay? Because lymphoma is biopsy and radiate, okay? Glioma, resection, all right? Meaning if you say it's a glioma and it's a lymphoma, the person's going to get an operation they don't need, and that has happened. So that's a really important distinction. And sometimes, now, I mean, there's other things, right? The enhancement pattern, snowball kind of thing, they can be different, but they can both be periventricular, both cross the corpus callosum. So sometimes that diffusion can bail you out if you're having trouble making that distinction, and it's a really critical distinction because it affects the patient's treatment. It's going to be an older patient in this, but that is a really important, and the diffusion can be useful there for the reason Dr. Pomerantz mentioned.
Yeah, this one will diffusion restrict if we had one. Shall we go on to the next one?
Yeah.
Yeah, the question is, what do you tell the parents from a prognostic standpoint? That's a question clearly for a clinician to answer. What do you tell the parents?
It's going to be very bad. I mean, there's no question. It's worse than a medulla, really.
But how do you
Yeah.
I mean, what do you say?
Well, the outlook, I probably would do this in conjunction with pediatric oncology, and try to come to the people, to the folks, and just say, first of all, there's going to be a surgery, but it's a decompressive surgery. It's not a curative surgery, but it's to forestall this imminent problem. Okay, then we're going to move on to treatment, and then have somebody from oncology say, okay, and we got a plan, and so this is what's going to happen, this is what's going to happen, this is how we're going to take care of this child. Okay, and I probably wouldn't, I tell them it's a very serious problem, and we don't know how it's going to turn out. I wouldn't probably be quoting statistics as far as survival and stuff at this point. But I would probably kind of do it from the standpoint of, okay, this is a really terrible problem. We don't have control over every aspect of it, but there's things we can do, and we have a plan. Here's what we're recommending to you. As I say, and also just tell them, hey, look, the patient needs decompression. This is not a curative surgery. There's going to be treatment after that required.
I don't pretend to be an accomplished clinician, but I do have a strong clinical background, and I see patients as a radiologist because I get a lot of weird cases. And one thing I have learned is even though people want the truth, they don't want the truth all at the same time. So you need, you give it to them in very small increments so that you gradually kind of lead them, to the final answer, and that may be over a period of time, over a period of days to weeks. Sitting in front of somebody and saying you've got stage 4 breast cancer and you've got, the average, life expectancy is 90 days. They don't want to hear that. And, you can't put an expiration date on anyone because you really don't know. So you have to give it to them gently, even though your inclination as a scientist and as a doctor is just to, tell them the truth. They really want to hear the truth, and they say they want to hear the truth. But in reality, they don't want to hear the truth all at the same time, right at the beginning.
But I think that is really apt with all this genetic stuff that's come out about these tumors, how much you don't know, right? Meaning, I used to run into people and say, oh yeah, this guy had a glioblastoma, but he's cured. Well, now we know why, because his IDH1 was mutant type, okay? And, so it's different than these other tumors. Our understanding of how these tumors and their behavior, right? So we're resecting some high-grade gliomas and not others. Some seem to do better, and, why? We don't know that. So you really do not know a lot about that tumor and how the person's going to do, and there's always surprising results. And now, as I say, we start to understand it, but obviously the level of understanding is different. So you can't sit there and tell somebody, hey, I know exactly how, what's going to happen to this person, because you're often going to be, we have a limited understanding of it. So, you really don't know that. I mean, you can couch it in some terms of probabilities, but, I've seen surprises, and so have you.
Of course.
So.
All right, the next case is a 32-year-old female, and she's got a pilocytic astrocytoma, status post, left-sided craniotomy.
Yeah, so this is a good one because, you know, we've already gave you the diagnosis, but it's a pattern you should recognize, but in a different location, right? So that's what's interesting about this case, right? Cystic mass with a mural nodule. So you're used to seeing that in the posterior fossa. This is a young person, okay? But here we got one that's kind of got unusual anatomy, but you can kind of fit it into that pattern if you're kind of wondering about what's going on with this. Do we have the post?
I believe we do have a post.
Yeah.
Here it comes.
Okay, so you're used to seeing a cerebellar, hemispheric, cystic mass in a young person with a mural nodule, right? So that, nobody would have trouble with that, and that's a tumor that behaves very, well. People do really well with that. You can peel it out. But here's something that kind of looks like it, but not where you think it's going to be.
I've seen one supratentorial hemangioblastoma in my entire life. So if you're making that diagnosis in the supratentorial space, you better think twice about it. Even though, they resemble each other in the posterior fossa quite a bit. So the fact that this is supratentorial, is good news for you in terms of differential diagnosis. Now, I'd like you to formulate in your head kind of the family of cystic nodular lesions that would occur in the supratentorial space. And because there is a differential here. And, it's in a slightly weird place, isn't it, for a pilocytic tumor? It's not awful, but, down in the orbitofrontal region, this is the orbitofrontal gyrus. These are the gyrus recti right here. This is affected. This is the diagonal band of Broca there. You're right below the subthalamic nucleus of Lewis. And so what types of lesions would you consider? Well, one you've already seen, the DNET. Now, there's something here that goes really against the DNET, and that is this very nodular enhancement. DNETs are classically supposed to not enhance. Well, I've already told you my experience is that there's some enhancement. It's mild. But this is just too intense and too nodular and too mass-like. DNETs like to make cysts low down in the brain, especially temporal, but they can be subfrontal. But it's usually not one large coalescent cyst. It's usually multiple cysts, just like I showed you. Another mass that is cystic that will have some nodular enhancement is the PXA, the xanthoastrocytoma. And these may have a little bit of high signal on T1 without contrast. They are also associated with some mild dysplasia in the neighborhood, and they're low-grade lesions. So that would be a lesion that's in the differential. They can have nodular enhancement in funny places. They kind of like the periphery of the brain more than this lesion does. So that would be one consideration. Another lesion that can make a cyst and nodules is the parenchymal supratentorial ependymoma. Most people think of ependymomas as being intraventricular, but not infrequently they are parenchymal due to ectopic tissue in the brain. So they can make nodules and cysts. So that would be an interesting and important differential diagnosis because those are potentially fatal lesions, and pilocytic tumors are potentially curable lesions. They have a pretty good prognosis. Any other nodular cystic lesions that you would consider in the differential diagnosis? I'm not sure there are too many others. Maybe the only other one would be ganglioglioma. That can make cysts. That also is one of these lesions, like DNET, like PXA, that is associated with dysplasias. I have seen them cystic with nodularity. 30% of them calcify, a little more common in men. They like the temporal lobe, second most common frontal lobe. So, that would probably be the differential
and the
diagnosis.
age is good.
Here.
When you think of neural line tumors, the ones that Dr. Parr, the young adult group, okay, the older 60-plus group, they're going to get gliomas, GBMs, but when you're thinking of these lesions, that kind of young childhood to young adult group is the neural line, the spot for them.
I think I'll say a few words about this tumor since it's such an important tumor to identify. We typically think of it as a pediatric tumor, but we see them in adults. This is a 32-year-old. The 10-year survival for this tumor, it's a World Health Organization grade 1 lesion, is over 90%. Many of them are cured. They're circumscribed. They're non-infiltrating. You know them as a cyst with an enhancing mural nodule. Now, when they're in the posterior fossa, there's a very interesting aspect to the hemangioblastoma that the pilocytic doesn't have. And that is when you have the cyst and the mural nodule, if you look at the mural nodule in the hemangioblastoma, you can actually see the vascular voids around the nodule. And you don't ever get that with pilocytic astrocytoma. So if that finding is present, then you can make the distinction. If the patient has other signs of von Hippel-Lindau, no problem. But sometimes it's an isolated phenomenon. Some people have said that size allows distinction. I've never found that to be helpful. The vascularity has been the most helpful finding for me. The common locations are cerebellum, cerebral cortex. Pilocytic tumors occur in the hypothalamus and the optic nerve and tracts especially. You see pilocytic astrodysplasia or pilocytic tumors in neurofibromatosis type 1. And those putter along at a very slow rate. But if you get intense enhancement and bulkiness, then you're probably into a true malignant glioma. I won't talk about the histology much. For those of you that are taking exams, Rosenthal fibers may be a multiple choice question. But pilocytic astrocytomas tend to involve the subarachnoid space in the optic nerve and in some other weird sites. Frequently, these tumors have rearrangement of chromosome 7q34, and I've got some of the other genetics here for you to read about at your leisure. The fusion gene is most frequent in the cerebellar pilocytic astrocytoma. It's found in more than 70% of cases. Extracerebellar pilocytics can have the fusion gene or show other mutations, and I'll skip over a discussion of the MAPK pathway right now. Now on spectroscopy, these tumors are kind of weird. They've got lactate in them. And I'm not sure I can explain as a scientific person biochemically why that is, but I believe there is an explanation. I just don't know it, and I should learn it next time I have this course. But lactate is elevated in pilocytic cerebellar astrocytomas. Some have said that this is a useful, when present, differentiating feature from hemangioblastoma. Frankly, I've never had a problem differentiating big hemangioblastomas from pilocytic tumors based on vascularity myself. And the amount of lactate is weird, not only in the fact that it's present, but it correlates with the size of the cyst. So the contents of the cyst, for some reason, must have lactate in them. It has nothing to do with how malignant the lesion is. So that's also kind of strange. On CT, it's a low-density lesion. It's slightly denser than CSF. They calcify about 10% of the time. You'll see enhancement 75+% of the time, but occasionally you'll come up with a pilocytic and you won't have a nodule. So it'll simulate a porencephalic cyst or some other, benign cyst, and that's also kind of weird too. So, this is a weird tumor with some unusual behavioral characteristics that are worth mentioning.
So you look at it, you give a differential and say, okay, I think it's this or that, and you're done, right? Well, not if you want to be really top drawer, right? So the next question is, okay, well, what's going to happen? So how are they going to get to it? Because you might be able to make comments that will help them devise an approach. So here's a craniotomy that's been done, right? So it's not like you just, here's a lesion, they make a hole over it and take it out, right? There's limited approaches to the brain, and this is a classic one. Your pterional craniotomy based on the sphenoid wing. You start with a burr hole right here, and that gives you access to the anterior and middle cranial fossae, okay? And then same one you would use for an aneurysm, and a pituitary suprasellar lesion, right? Because you can go through the sylvian fissure and use the fissures of the brain, okay? So the first thing, so when you see a lesion, you say, okay, is this coming out or not? Okay, if you say it's coming out, then you got to start thinking, well, coming out how? For example, in a pituitary, if there's a sellar or suprasellar mass, you should be looking and seeing, is the sphenoid aerated? Because if it's not, they can't use a transsphenoidal approach. Are there kissing carotids? Because that's another contraindication to the transsphenoidal approach. Okay? So you have to start learning these approaches because there's a limited number, because once again, you can't just go through the motor strip or anything. All these things have to go through an area of brain that gives you access without creating a deficit, or at least not a serious deficit. So you got to start being familiar. For example, if you say this has to be done through a transcallosal approach, then you got to start looking at the anterior cerebral arteries, okay? Because you have to spread those to get to the, meaning if there's an anomaly, you can end up with a disaster. It may preclude that approach.
Like an azygous vessel.
Like an azygous anterior cerebral. Very important finding, because you'll get down there and say, oh, there it is, move it over, and you tear it, okay, because you don't know the anatomy of it. So you got to start learning these approaches so that you can take the next step and say, and when I describe a tumor, I describe where it is. Okay, it's elevating the middle cerebral complex. It's pushing the anterior, what structures are they going to have to deal with, right?
Does it matter? Would you do a pterional approach if it was on the left side?
Yeah.
You would?
To the midline, yeah. Because you have to work through the fissures of the brain, okay? So the next one is going to be down, a middle fossa approach. You can go subtemporal, okay? And now there's all these skull-base approaches where they're doing very extensive work just through the nose, okay? Taking out the whole clivus through the nose using endoscopic techniques.
So the pterional approach I get. Could you just explain the middle fossa approach?
Yeah, middle fossa would be down here.
Okay.
Okay, and so you lift up the temporal lobe, okay, and you go right over the tentorial edge, and you're going to see the midbrain. Like I was saying, remember that midbrain cavernoma that we had? I did one with a friend of mine that way. We did a subtemporal lift up the lobe, and you can see the midbrain kind of over the tent. Sometimes you have to section the tent, but you have to worry about that because the fourth nerve comes right into the tentorial edge, so you have to know where that is. Give yourself a little room, and you can take it out that way. Okay, so you have to kind of get familiar with the anatomic considerations of why somebody how they're going to actually, if it's coming out, how? So that you can comment on the appropriate things, meaning say, wow, you're going to run into the middle cerebral at the end of this resection, so they're looking for it. Okay, or you can't get this out without, So that's what they're going to start thinking as soon as they see it. As they say in neurosurgery, location is more important than what it is. What it is most important to us. Where it is in relation to everything is what's most important to them. So you got to kind of get keyed into that.
Now, I think this one is probably arising from the optic pathway.
Right. It's wrapped really around the chiasm, right?
It might have come from the chiasm.
Yeah.
Because there's a lot of solid tissue in the left portion of the chiasm, that's directly
right. And so these optic gliomas that we showed on, those are pilocytics, right? And this is a pilocytic. Mm-hmm. So kind of related. Now this one's different, has a cystic mural nodule, but it may very well be coming from part of that spectrum. And actually the NF1, right, is associated with the ones that are not NF1, that is the optic apparatus pilocytics that are not NF1 are the ones that involve the chiasm. The NF1s are more likely to involve the intraorbital optic nerve, and the non-NF1 optic apparatus ones do worse. Okay, so if you can look at it and say, well, this patient doesn't have NF1, well, that may very well be true. Okay, and particularly true if it's not involving the intraorbital optic nerve, but the chiasm and optic apparatus.
And
so this is kind of...
Here's the chiasm on the left. Look how tight it is relative to the chiasm. I think that is the site of origin. Here's the axial projection. Coming down, you never actually see a left chiasm. And you do see one on the right there.
Yeah.
And then here, we've got the right chiasm and then the left chiasm. It's either involved or arose from the chiasm itself,
Right.
and I suspect that's why they were ginger about resecting
Right.
it.
Yeah, I mean, and the blood supply too. So what they did was they'll split the sylvian fissure here, And the same thing you do for a supracellular tumor or cranio or an aneurysm is what, as you're going to give your approach. And they probably got here and got into the cyst, but you know they can't peel it off the chiasm. The chiasm, if you damage it, the blood supply comes from below. You know, so you got to be sure not to devascularize the chiasm. So that's why probably was not a complete resection, because it, you know, it's like one of these hypothalamic or optic pathway gliomas, right? It's part of the thing. It's not, you're not going to find a plane as you would find with this pilocytic in the posterior fossa.
Shall we move on to the next case? Pilocytic astrocytoma, probably arising from the optic apparatus with a cystic and nodular component. 41-year-old male
Neck mass, yeah.
with frequent fevers, coughing, left-sided headaches, and left tonsillar enlargement. I'm going to go with my usual 3 up and probably put up the first 3 images that I have. I've got a sagittal T2, a coronal T1C minus, and a coronal a coronal proton density spare or special or stir. This one, they often label them all stir. This may be a stir. I know General Electric labels all of their fat suppression stir, even though they are not properly stirs. They are actually something called special. They don't put that in the name up top, at least on the older machines. And there is a difference between the two, although they're both types of fat suppression. One spectrally sensitive, the spare, the special, and the spur, and the stir is non-spectrally sensitive, used more frequently at low field. So I'm scrolling around with some big findings present, and so are you. And I'm going to let you scroll a little bit because this is a very complex case. It delves down a little further south into the head and neck. And I'm going to put up my C plus T1 next to my C minus T1, my non-contrast T1, now that I have found something. And it's vascular. It enhances. It's fairly large. And there are some stippled areas of low signal inside it. Now, the differential would include calcium, but calcium isn't linear, at least not usually. Maybe in oligodendroglioma it's branching or linear, but not usually in most masses. Is something branching going to be calcium? You know, maybe an actinomycosis, you could have branching calcification. But other causes of hypointensity that you would consider, flow void, obviously, and there are some prominent vessels at the edge of this, but it does have a very circuitous internal character to it. Siderosis you would consider, but that's going to be almost salt and pepper uniformly stippled. Now you can get very salt and pepper-like looks to paragangliomas because the vessels are so small if you cut them in cross-section, but if you catch them in plane, they're going to be more linear. And that looks a little peppery right there, a little salt and pepper, and then it looks a little linear over there. What else might give you low signal? Bubbles. You sure as heck don't want to miss gas. We've been involved in a few cases as consultants where gas was missed and it ended very, very badly in the realm of MSK. So if you're at all suspicious of gas and you're a little insecure about it, get a CT. Don't even hesitate. There's some prominent vessels inferior to this thing. Other causes of low signal, another one would be air. Not necessarily gas bubbles, but communication with an aerated structure like a sinus. And then you have, various artifacts that are related to prior instrumentation. There can be absolutely nothing on the X-ray whatsoever, and the surgeon leaves behind a path of destruction. No, I'm just kidding. Leaves behind a path of metal, small little metallic flakes that are beyond the resolution of even an X-ray, and with their instruments, and those show up very frequently in MSK and in head and neck surgery too, as small foci of hypointensity that become more bizarre in their shape and signal on gradient echo imaging. That's called blooming. So that's kind of the spectrum of low signal abnormalities within a mass. This one is obviously none of those other than vascularity. It has to be vascularity. And hopefully you have dialed into the fact that there is one on the other side, or something on the other side. Let's keep looking, shall we? Or maybe something else on the other side. It's getting a little more convoluted. Let's put up some axials. I'm sure you already have. I'm going a little more slowly. Let's get those axials up. I'm going to make mine a little bigger. I've got my C minus on the left, T1, my T2 in the middle, and my proton density fat suppression, kind of the detection sequence on the right. And our large lesion, true to form, is somewhat hyperintense with exuberant internal vascularity. And Dr. Schupek's going to talk in a moment about what it's doing to the carotid circulation, which is relevant. But while we're at it, let's look at on the other side. There's a lesion on the other side, and we're going to talk about, Dr. Schupek's going to talk about what it's doing to the carotid circulation on the opposite side. And there's more than one of them, or at least a daughter lesion next to it. And there's probably another lesion up higher.
Is that in the jugular foramen?
That's in the jugular foramen on the right.
Oh,
That looks more similar to this lesion.
right.
So this one looks less similar. This one looks more similar.
Isn't there another one on the left, higher?
Oh yeah, right there. Right there. Yep. There sure is. You stole my thunder, but that's okay. My thunder needs stealing. My wife will tell you that. All right, so let's get the C plus up. And there's your lesion on the left. So let's talk about the carotid anatomy, and I'll let you drive now.
Okay. So here we are, getting the Glomus brothers back together again, getting the band back together, because you got them all right here, just like in the high school picture, okay? So Glomus jugulare, okay, jugular foramen coming from Jacobson's or Arnold's nerve, okay? And then you have this one, and then you have this one, right? So what are these? If that's a Glomus jugulare, what is this, and what is this? And there's a couple ways. Are they the same, or can you tell a difference? Well, next brother in line is the Glomus vagale, okay? So how do you say, well, is it a vagale or is it not, right? Well, Dr. Pomerantz already pointed out, see how the vessels are pushed forward, okay? And Glomus vagale is described, if you read about it, as being 2 centimeters below the skull base, right? If you're kind of wondering. And, you know, when I read that, I said, yeah, I'm sure. Everyone I've ever seen has been exactly 2 centimeters below the skull base. And I measured this one, and it's 2 centimeters below the skull base. So it's too high, because if we look at this other one, right, see how the vessels here, so here are the vessels on this one pushed forward, but here is this one, right? So this is different, because the carotid bifurcation is split, okay? So these are two, they look the same because this thing's so huge, but they're two anatomically different things, because this is a carotid body at the carotid. We used to call it a chemodectoma, okay? And this is a Glomus vagale, so you can tell that by the location related to the skull base is a little higher, 2 centimeters down, okay, pushing the vessels forward. And this one splitting the bifurcation is kind of a classic. And this used to be a classic sort of angio sign where we were, you know, the kind of pre-CT days, you would see this with the carotid all splayed out. Okay, and then this Glomus jugulare. So you got the whole thing here.
probably on both sides, glomus
Right.
jugulare, Arnold's nerve, and then Jacobson's nerve, tympanic canaliculus. Those you may find in the middle ear. And now you have to consider multiple endocrine adenomatosis syndrome, right? Because you got multiple glomus tumors, you got a chemodectoma. So then what do? Well, of course, you continue your search throughout the rest of the brain. You cover the rest of the head and neck, and you're kind of done, right? Well, not really. I mean, you got to know what is associated with multiple endocrine adenomatosis, type 2 or type 2B or type 3. Well, NF1 is actually associated with multiple endocrine adenomatosis. So that would be something you'd want to be searching for. Got a couple of nodules here. They look more like lymph nodes than anything else. What else do they get? They get adrenal lesions. So you might have to check the adrenal glands, anything endocrine. But the one big one that you don't want to miss is medullary carcinoma of the thyroid. So let's see if he's got that. I mean, you might not think to look for it. You get so enamored with the love affair that you're having with the glomus twins, They're back again, it's a fantastic case. It's an amazing diagnosis. It's beautiful in terms of the imaging. I know that sounds crazy, but that's who we are, radiologists, This is true beauty in radiology. And then we get down low, and we forget to finish the search. And lo and behold, that is not a normal thyroid right there. Look at it really carefully. Now, we don't have the answer yet, but I can tell you the calcitonin levels were elevated. That much I do know. I found that out 2 days before coming to this course. So this patient's going to have medullary CA of the thyroid. Now, I don't know if he's got one or more, but so the search isn't over yet. This patient needs to have abdominal CT and pelvic CT. Anybody have any questions about this case? 50% of these, by the way, are heredofamilial. They're associated with abnormalities in the succinate dehydrogenase pathway. There are about 6 genes that have been linked to this disorder, and you can test for these genes using a $100 kit like 23andMe.
Right. Now, these glomus jugulare, they invade the jugular, right, and can include the jugular, and that's part of the difficulty in management, right, because what you've got to do is kind of go above and below, and so 9, 10, and 11 are right here. You want to kind of save those. So this is a day's work right here, okay, and managing the vein, so you have to get down here below it, here above, kind of work your way, So big case, but they may want to get a MRV and see what the status of the vein is, okay? And
although the flow looks pretty good on this one, surprisingly, because it's a pretty big lesion down low and up high.
Yeah, but you're probably going to end up occluding the vein as part of this approach.
Yeah, and most of those nerves, 9, 10, and 11, they kind of travel together like triplets. So you get these syndromes, these jugular vein syndromes, Vernet syndrome, Villeray syndrome. You can Google those at your leisure. We'll have them on MRI Online. In fact, we do. And but it's said that for you test takers, it's said that these nerves are predominantly in the pars vascularis of the jugular vein, with the glossopharyngeal having more of a nervosa portion of the jugular foramen in its course, although most anatomists now feel that the glossopharyngeal has contributions to both sides of the jugular foramen, the nerve side and the vascular side. But this is a case, although we don't have the genetics, most likely of multiple endocrine adenomatosis, with most likely medullary carcinoma of the thyroid, but with a glomus vagale and with a chemodectoma on the right, separating the carotid arteries, and with an elevated calcitonin level, and the imaging is not over. That thyroid thing is tricky, isn't it? If you don't think of it, if you don't think of the syndrome and go after the thyroid, you are never going to see that lesion. And it's really important because that's a malignant lesion. 18-year-old man with 6 nerve palsy, Abdusen's palsy, left eye, and diplopia. So all those genes for glomus vagali, they're called SDH genes, succinate dehydrogenase genes. There's 4 of those, and then there's one called the MARC gene for any of you genetics fans out there. So 18-year-old looks like they have invested some money in braces for their child.
Okay, so there's 6 nerve palsy. So whenever there's the complaint is of a nerve palsy, someplace in my report I try to follow the whole course of that nerve, and say, for example, the bulbopontine fissure, okay, in this case, and remember that it kind of crawls up the clivus in Dorello's canal, okay, and then into the cavernous sinus, most medial, okay, in the cavernous sinus. Now,
So on this side, it would kind of go this way.
yeah, look at image, series 31, image 7. I was going to see what you thought about that.
Series 31, image 7.
7. Because
Seven.
see right there, is that the 7th right there next to it? I don't know. That little dot there.
Is that the 7th nerve?
Yeah,
Or 6th nerve? 6th nerve.
I was
That
wondering
probably,
if that was where the 6 is getting.
that
nailed.
is the 6th nerve, but here's the 6th nerve on the other
Right.
side, that little nipple right there.
Right, but I thought this might be the
I
place
think you're right.
of involvement.
I
You know,
think you're
so
right.
I like to follow if they're talking about a nerve palsy, I like to just anatomically go through at some point in the report and say, hey, there's nothing at the bulbocavernous fissure, there's nothing in the no mass in the clivus, no mass in the, cavernous sinus. So they know and you're thinking through it, and they know you're thinking through it.
And that, a classic retroclival lesion that you would have clinically and get shown on an exam and get asked about, is one that produces a 6th nerve palsy because of that length, that course of the 6th nerve coming out like this and then scooching upward behind the clivus and then hooking forward to enter Dorello's canal before it goes into the cavernous sinus. Now you can see the nubbin of it right here. Unfortunately, the slices aren't thin enough to show its entrance into Dorello's canal, but I'll just draw over it right there, and now I'll take it away, and I think you can see it. And you can see why the nerve is getting clipped right here by this mass. So a couple characteristics about the mass before Dr. Schupek takes over. It's got kind of a flat edge to it, and it's really pushing on the lateral aspect of the dura here, but it isn't crossing the dura. It isn't invading the dura. It's not invading the brain. And we said in our earlier assessment of the brain, one of the first things we do is it intraaxial or extraaxial? This one's extraaxial. Then we might look at the vascularity. Well, it's very vascular, somewhat homogeneously vascular, and it happens to also be encasing or at least encroaching on the left carotid artery. Next, the signal, well, it's mostly intermediate to lowish in signal with some internal kind of speckled high signal, and that's good for most solid desmoplastic and or fibrous lesions. So that would fit pretty well with this particular diagnosis. Now, schwannomas and meningiomas overlap quite a bit, so you can't use signal by itself to decide between the two, but if you average, all schwannomas versus meningiomas are lower. There is such a thing as a cystic meningioma, and we've seen meningiomas with big cystic caps on top of them, so they can kind of do whatever the heck they want. But the classic or typical meningioma would be a gray lesion, kind of like this, with some speckled microcysts inside it. It might have a little spray of calcification the so-called Samoma body. Remember that from histology, calcification? You might see that nicely on CT, harder to see on MRI. It often demonstrates the mother-in-law sign or father-in-law sign. You know, the mother or father-in-law comes early and never leaves. They stay late, and they're very intense when they're there with the grandchild. Well, that's me. I admit to that. I come early, I stay late, and I'm pretty intense with the grandchild. Actually, my wife's even more intense. But being a grandparent is totally awesome and a different experience than being a parent. All the fun and none of the worry or hard work, at least not as much worry or hard work. And so coming early and staying late for the vascular enhancement, very typical for meningioma if this were to be one. Let's look at the T1 characteristics of it prior to contrast enhancement. I think we've got it right here. Kind of very bland, right? Meningiomas don't bleed. You know, they're firm, rock-hard lesions, as Dr. Schupek will attest to. And they may calcify, they may not, but they're hyperdense on CT. They incite a fair amount of periostosis, and they may give rise to a tail of enhancement, the so-called dovetail enhancement along the meninges. But again, on T1, very bland, but a nice way to trace the anatomy. And this one is butt up right near the orbital fissure. Fortunately, it's a little ways away from the orbital apex, but it is near the fissure. And as we said, it's near the carotid, it's clipping the sixth nerve, and I wouldn't be surprised if it isn't getting some other cranial nerves as well that they just haven't recognized yet. Any comments you have on this one?
Yeah, one thing is, Dr. Palmer was just talking about a meningioma, but you know, crossing compartments like this, posterior to middle fossa, not too many things do that.
That's true.
And that's a little, and also in this age group, at least my experience, I don't know, but if you have had the same one, but meningioma, I think there's a pretty strong female predilection, and at least in this, I mean, meaning I'm trying to think of an 18-year-old that I've taken a meningioma now. I can think of very young females that have taken a meningioma.
Unless they have NF2.
Yeah, right.
Yeah, unless they
so
have NF2.
That's the next thing is you got to comment on all the other cranial nerves, right?
Because or heredofamilial meningiomatosis. Now this one doesn't really have, a dovetail sign.
Right.
It doesn't have good meningeal enhancement. And the other thing it has that I don't really like for meningioma is it makes this sort of figure of 8 like a dumbbell.
Right. So that's classic for this trigeminal schwannoma. That is the crossing compartments kind of thing. And also not a big dural tail, no hyperostosis, So, I mean, to me, meningiomas, you'd mention it, but I think you're going to be favoring trigeminal schwannoma, this kind of classic, that figure 8 two-compartment pattern.
Yeah, and in terms of the enhancement, it's pretty vascular, but of the two, meningioma is going to be even more vascular than this, probably.
Yeah.
I mean, it's definitely on the average more vascular than schwannomas, consistently. And, this isn't really that flat. It has one flat surface back here where it's pushing up against the pons, but it's not particularly flat against its dural surfaces. In fact, it's more round against its dural surfaces. So I didn't want you to get, too comfortable right away, and want to see if I could talk you into something by giving you information. But this, I think, is a schwannoma.
Yes.
It is a schwannoma.
Yeah.
And about 25 or 30% of them will sit in Meckel's cave alone. About another third will go, middle fossa, posterior fossa. And then a small percentage of them will be simply right at the root exit zone, and the other percent, I don't know what the other percent represents, but about 5% of them will be located here. So a third in Meckel's cave, a third dumbbell, and in the middle fossa and posterior fossa, and about 5% right at the origin or takeoff. And my guess is the rest are combinations thereof.
Right. And so, the relation to the carotid is going to be important to the approach taken. And the relation to the sylvian fissure is going to be, whether you can kind of peel back and dig it out or do you have to go this way. You have to give some thought to that. But, the fact that it's got posterior fossa extension, I mean, that's what's probably going to make it require surgical treatment at some point. Meaning, if this got twice as big, so if, I don't know what they'll end up doing, because you're not going to fix his 6 nerve palsy by taking this out, probably.
So would you watch this for now?
I think I might, and just see the behavior of it, because I have seen people with these things that have been reasonably quiescent, but as soon as it starts getting bigger, you're going to be kind of screwed, as far as having to do something.
Okay. Anybody have any questions about this case? I would not suggest NF2, even though there's only one lesion at this point. There are discrete criteria for NF2, so having a single schwannoma wouldn't meet that criteria. I certainly would go through the entire image, cranial nerve by cranial nerve. It wouldn't take me, an hour to do that. I'd do it pretty quickly, but I'd examine every single cranial nerve looking for schwannomas. I'd check the rest of the brain for meningiomas. I would not necessarily go down and do a spine survey, to look for NF2. If this is a solitary lesion, I'm done. The question is, would assessing cerebral blood volume have any value in differentiating meningioma from schwannoma? I don't know the answer to that. Does anybody? I mean, clearly meningiomas have more vascularity. They're brighter, they enhance, earlier. So if you did a cerebral blood flow analysis, the curve for a meningioma is going to look something like this. Now, I wouldn't typically do a DCE MRI for this, but a meningioma would come up early, and then it would persist for a pretty long period of time and probably continue to rise like that, whereas the curve for a schwannoma is going to look more like that. So I think a cerebral blood flow analysis would probably be more distinctive, but I don't know, honestly, whether a cerebral blood volume would help you in terms of differentiation. It's beyond my pay grade. You can see there's a fair amount of overlap in the appearance of a meningioma and a schwannoma. I think I probably had most of you talked into it. I was selling it really hard.